Hello guys, welcome back to Medicodiy, and today in this video we'll be talking about infantile hypertrophic pyloric stenosis or IHPS. Infantile hypertrophic pyloric stenosis, it was initially considered as a congenital condition, but now with the recent studies it has been found out that it is an acquired condition and it is a medical emergency. Infantile hypertrophic pyloric stenosis, it occurs due to the hypertrophy of the musculature of the pyloric antrum, especially the circular muscle fibers, which causes the primary failure of the pylorus to relax. In this condition, the duodenum is normal. The clinical features of IHPS is that it usually presents in 2nd to 8th week after birth. Rarely it may present after 13th week of birth, and it is common in the firstborn male. The male to female ratio is 4:1, and there is genetic predisposition to this disease. That is, if a girl has IHPS or offspring has high chance of developing IHPS, which suggests that there is genetic predisposition. Talking about the clinical features, the baby, it presents with multiple episodes of non-bilious vomiting, which is projectile in nature. And if the baby is premature, then the infants may have non-projectile vomiting. The baby may also present with features of constipation and dehydration due to recurrent multiple episodes of vomiting. And there may be loss of weight. And since there is recurrent vomiting, there will be loss of potassium chloride, so it may result in electrolyte imbalance. So there can be hypokalemia, hypochloremia, and there will be metabolic alkalosis due to loss of H+ ions. On examination, we can see that there will be visible gastric peristalsis. The direction of the peristalsis is from left to right across the upper abdomen. In this picture, we can see that here this is visible gastric peristalsis moving from left to right. And when the body is relaxed, there may be a palpable abdominal mass in the epigastrium region. It is olive shaped, smooth, firm, and moves with respiration, and there is impaired resonance on percussion, which is the most important clinical features. The investigation for the diagnosis of infantile hypertrophic pyloric stenosis can be done by USG or plain X-ray or the barium meal. In USG, we can see that there may be presence of a donut sign. In this picture, we can see that this is a donut sign seen on USG. And talking about the pyloric muscle thickness, it is more than 4 mm. The channel length may be more than 16 mm, and the transverse diameter is more than 13 mm. In plain X-ray, we can see that there is presence of single bubble appearance. In this X-ray, we can see that there is a single bubble. In the barium meal, there can be string sign, shoulder sign, or double track sign. In this X-ray, we can see that this is a string sign, and this is a double track sign. The differential diagnosis of infantile hypertrophic pyloric stenosis can be malrotation or volvulus or duodenal atresia, where there will be bilious vomiting, but in IHPS there is non-bilious vomiting. It can also be due to gastroesophageal reflux, but it is most commonly seen in infancy, and since there is projectile vomiting, it needs to be differentiated from intracranial hemorrhage. The treatment of choice is surgery, but before proceeding to the surgery, the electrolyte imbalance and the dehydration should be corrected. The resuscitation can be done by giving IV fluids. For this, 150 to 180 milliliter per kg per day of 0.9% saline with 0.15% of potassium chloride and 5% glucose should be given. Since there is stenosis, so oral feeding is discontinued, and the stomach is emptied with 8 to 10 FR of nasogastric tube. Surgery of choice for infantile hypertrophic pyloric stenosis is Ramsted's pyloromyotomy, which can be done via laparoscopic approach or via open supraumbilical incision. Post-operatively, the IV fluids should be continued until oral feeding is reestablished, that is within 24 hours. And even after surgery, the baby may have small vomitus on the first few feeds, but it usually resolves after 72 hours. But if there is persistence of vomiting, then incomplete myotomy or gastroesophageal reflux should be considered. There are certain post-surgical complications like duodenal perforation, hemorrhage, wound infection, and wound dehiscence may occur. This must for today. Thank you for watching the videos till the end. Do like, share, subscribe, and stay tuned for more videos. Thank you.